Now we're going to hear about managing diabetes and improving adherence, and what to do when they don't do their blood glucose levels, injections, press the buttons. I would like to introduce Dr. Phillip Bergman, Head of Department of Paediatric Endocrinology and Diabetes from Monash Children's Hospital. Phil.
Thank you very much, and I'd like to thank the organisers for inviting me to be involved today, and Lisa's an extremely hard act to follow. I think you've set the scene for the day and reminded us of what it is that we're trying to do, what we're all about, and all of us who work as professionals in any area involved in assisting young people and their families in managing diabetes. I think we all need to continue to remember the messages that we've just heard about what it is actually meaning to each child and each family each day. As I say, it's a really important message. So when we are trying to assist young people to manage their diabetes as well as possible, I think it's important that we are trying to do it in a non-judgmental way. Because nobody, and it's the same whether it's diabetes, whether it's asthma, whether it's cystic fibrosis, whatever condition, in whatever person, at whatever age, not one of us are in that person's situation. None of us know exactly what they're going through in their lives and what it is that may be making it more difficult for them to manage their condition and their situation in the best way. And right at the very start, Lisa made the point of getting us to all stand up and show, have we been perfect in every way in all of our aspirations? And I think it's fair to say that apart from myself, none of us are perfect. And I actually say that to the kids when I'm talking to them and say, look, you're struggling, you're trying hard, I know you're not perfect, not like myself. And then they have a bit of a laugh and we just normalise it. And then I say, yeah, look, I'm not even perfect, believe it or not. And none of us are going to be perfect in everything we do in our lives. So when we're trying to think of how to assist somebody, we need to remember that, and it's helping particularly around motivation. So what I'd like to do is initially talk about the medical consultation, and I know that some of the audience are medical practitioners, but everyone in the audience has been involved at some point in a medical consultation, whether it's as a health professional or whether it's as a consumer, and the concept of what happens in that can really set ourselves up to succeed or not succeed as well as we'd like. And then I'd like to talk a little bit about adherence and compliance and what they mean, because they've got very different implications, and why my talk is around adherence and not compliance. But all of the medical literature until a couple of years ago was about compliance. And then talking about the impact and how we might be able to make a difference in adherence. So the medical consultation is interesting. When we have a consultation, there can be a lot of pre-appointment anxiety and distress, because in diabetes we have a blood test that we can do once every 3 months, which talks about the average blood glucose over time, and we heard from Lisa about it's a numbers game, and it is very much a numbers game. And so somebody might be sitting in the waiting room waiting to come along, or even in the week or two beforehand coming along, and there may be a great deal of anxiety around what is that number going to be, what's the message going to be at this appointment, how are things going to be perceived. I've had people sitting in the waiting room, and those of you who've been involved in this area may remember seeing people sitting in the waiting room diligently writing out all of their blood glucose levels at the last minute, getting their record book out so that they're not told, oh, you didn't bring your blood glucose book today. Then that HbA1c news, it impacts. If the HbA1c, the average, is better than they thought it might have been, then that might be a really good, relaxed consultation. If it's not as good as it might have been expected, getting a message across about some other aspects of management may be impacted, because the person is just concentrating on, oh, where did I go wrong? What have I done wrong? What's the problem? And their thoughts are being distracted away from any ongoing consultation or discussion that is being undertaken. Now, if you think about any consultation that any of us have had in our lives, and we've all been in consultations one side or the other, as I said, we've only got a very short period of time with that health professional. We've got a few minutes. And if there's something that we need to improve, then that's what we really need to concentrate on. We don't need to spend an entire consultation, whether it be 5 minutes, 20 minutes, 40 minutes, whatever it is, saying, yeah, this is really good, this is really good, this is really good, when there are actually aspects that would be helpful to improve and change. So therefore, the things that need to change become the predominant part of the consultation, and that can become a very negative aspect. So we're concentrating on the bad bits. Then we may talk about the positives, and this is the challenge that I would put to all of us, that we need to address the challenges and the, for want of a better word, the negatives, but we also need to remember the positives so that the experience is not just repeatedly, every 3 months, coming in and being told, you're not doing this, you're not doing that, you're not doing that, fix this, fix this, fix this. Because any one of us going in repeatedly, year after year after year, week and month after month, you're going to stop listening, you're going to stop going along, and no wonder some of the challenges in adherence are actually getting people to come along to our consultations sometimes, and people don't want to come along. And then they leave with this message of what's going wrong and what needs to be fixed if we're not careful about how we present the information. So there can then be varying degrees of recall. So if you spend your entire consultation as a young person or the parent, and going through your head is all of the information around the HbA1c and why is it going wrong, and there's been a discussion about things that might improve the situation, perhaps, then it's not surprising if you walk out of the room and you don't recall what was discussed. And there have been a number of studies done over the years where somebody is interviewed as they walk out of the door. They've just walked literally out of the door and they're interviewed. What did you take out of that consultation? And then they go back into the room and interview the health professional, and they don't actually match. And some of the things that the person recalls was never mentioned by and it's been videotaped, and some of the things are never even mentioned, and they recall something different. So if we can't even get recall 5 seconds after somebody's walked out of the door, we're really going to be struggling if we're expecting somebody to remember what was discussed a week or 2 or a month down the track. So we need strategies to assist in that process, such as writing things down, recording, etc. So then coming on to definitions. It's a really important part that compliance and adherence are very different terms. I've been asked at a professional presentation in the last 12 months not to use the terms compliance and adherence in a professional presentation about diabetes. And I said, that's fine. There's no presentation to give now because adherence is a key component of how we do our day-to-day job. And it's a very big misunderstanding if we think that adherence is a bad term. Compliance suggests how does somebody do what they're told to do. Adherence is a term trying to describe how does somebody do something that they have agreed to do as a part of a management plan that they've participated in. That's how I see the term adherence. And if that isn't what the term actually means, then I want to find a term that actually describes that, because we shouldn't be telling somebody what to do. It is a team effort. And I tell families all the time and young people all the time, if the HbA1c is higher than it should be, it reflects on me as much as it does on you. It reflects on all of us because we are all in this as a team. So sometimes we will look at an HbA1c average across a clinic, and there might be a clinic that has a better lower average. And I could very easily get the average of the young adult transition clinic that I have go down by not trying to follow up the young people who struggle to come in and have a high HbA1c. I wear a high HbA1c as a badge of honour if it actually reflects that I'm engaging with the people and bringing them in. It might not be as high, it might not be as low as I really want, but it's much better to come along and be reviewed and be assisted and have an HbA1c of 10 rather than disappear and never see anyone and struggle even more and have an HbA1c of 12. So we've got to have an aim that is realistic. So we've got to work with people to get the best long-term outcome, and that's what the difference is between passive or active, or are we dictating to somebody or we're working as a team. So what is the impact of reduced adherence? It's widespread. It's not just diabetes. Some of what we are talking about today will be able to be utilised in managing and assisting people with diabetes, but I think this is relevant to all aspects of any age group, any medical condition, any situation. And the literature in this is predominantly across many different situations, including probably the largest area is HIV medicine, because it's a relatively new area of medicine in the last 20 or 30 years. So people came into it with no background, and they then struggled to get these people with HIV to get as good an outcome as possible, because they would struggle to take very complex medical regimes. And the literature and the knowledge that's been gained in that area is able to be spread across all areas in terms of adherence. But asthma, liver transplantation, various different areas. So the amount by which somebody is able to follow a guideline 100% will vary. So some people will only manage 10% of what they're asked and planned and agreed to do, and other people will get 90% or even 100%. But it varies quite broadly. And different parts of the same management plan may be able to be followed more effectively than others. And I'll show you an example of that in a minute. But diabetes is complex. We heard all about the different aspects of life living with diabetes. And it's not just one thing, giving an injection. It's giving injection, doing blood glucose tests, monitoring, assessing, diet, etc. So I'll go through it in a bit more detail from diabetes point of view. Now, the effect of poor adherence has major impact on outcomes, and I think that's really important. The study that I've quoted there from quite a while ago, but the literature really still brings this out. Across thousands and thousands of studies looking at following a management plan that's agreed upon, the more accurately you follow that management plan, the more likely you are to have a better outcome in whatever measure you're doing. Interestingly, there are about 6 out of a couple of thousand papers that in that meta-analysis that said if you don't do what you're told and you do the opposite, you do better. I don't know quite what was going on in those 6 studies, but the vast majority of studies would support if there's a management plan, we all agree on it, then it's most likely that that's going to have a good outcome in the long run. And there are different outcome relationships depending on what we're talking about, whether it's a long-term or short-term issue, whether it is a more serious medical condition or whether it's something that's relatively minor, whether it involves medications or other behavioural strategies, and also paediatric studies. So if we know that it's important that if you can't follow and work with that management plan that you've agreed to, then why does it happen? You know, if we're told this would be a really good thing for you to do, and it should be simple for you, why isn't it able to be done? And not one of us stayed standing after those 4 or 5 questions from Lisa, so I think we've all got personal experience of not always following the plan. You know, have you been to the doctor and been given a script for an antibiotic for 5 days, and 2 days later your cough is gone and you feel all right, and you think, no, I won't bother finishing those last couple of days. That is not following the management plan. Now, probably it doesn't matter in that situation most of the time, but if you are agreeing to a plan involving 4 injections a day and you're doing 3 injections a day, that can have an impact. So there's all sorts of reasons, and I won't go into specific detail, but if you don't believe that it's going to help you, then it's not likely that you're going to do what you've agreed to do. You might agree to do it in the room just to keep the doctor or the educator or whoever happy, but if you really truly don't believe it's actually going to be helpful to you, or don't understand how it might be helpful, then you're not going to undertake the treatment. There may be a specific real or perceived barrier. So there may be side effects, and we have to talk to people about potential side effects, for example, and that's a useful thing, it's an important thing, it's allowing people to be fully informed. But equally, sometimes the perception of those side effects will overcome the understanding of the benefit, and therefore that will stop us doing something. There may be financial constraints. Having diabetes is an expensive exercise. The amount of money that is expended, even when you are given a device that is relatively cheap or government funded or whatever, there is still costs of tubing, there's cost of insulin. Even with the healthcare cards, there is still outlay. So it's an expensive exercise, and some of the therapies we offer are very expensive, and that might be a reason why people choose not to take it up. The demands of the treatment, it's actually just really hard work and time consuming. It takes you away. I talk to families all the time about what's happening at school. If there is something going on in management at school that stops that young person from being with their friends, I know what I would choose. I would choose my friends over doing something to do with my diabetes. So anytime there's a barrier that gets in the way of this young person being with their mates at lunchtime, then let's get rid of that barrier if we can. Sometimes we can't. But if it's as simple as they've got to walk 20 metres down the corridor to the sick bay to give their injection rather than doing it in the classroom, if that it sounds like a great idea from the school and they're doing it to support everybody, but if that means that all of their friends rush off and they then spent the next 20 minutes trying to find them in the playground, then eventually they're going to say, I don't really want to go down to the sick bay, I'm just going to run off with my mates. So it's getting inside the head of the young person and thinking, well, what would you do logically if it were you? Not judging. It's not saying this is a right thing to do or a wrong thing to do, but there are some times where something will happen that is not helpful. So a response where you run off with your mates is an understandable response, but it's not a helpful response in managing the diabetes if it leads to not doing your blood test or not doing your injection. So we've got to have that difference between what's helpful and what's understandable. And there's many things I absolutely understand why somebody might be doing it, but I can't not tell them, actually, I get it, I understand why you're doing it, but it's not a really good way to manage your diabetes, and therefore we've got to think of how we overcome those barriers. Mental health is a very, very key part of the management of diabetes and any other long-term medical condition, because if you have a primary medical situation, including depression and also particularly in diabetes anxiety and hypoglycemia anxiety, whether it be in a parent or carer or the young person themselves, then if we don't address that, then it's very unlikely we're going to be able to address many other aspects of the adherence. And I know I can see a few of my colleagues, psychologists and social workers in the audience who they are key members of any diabetes team in supporting and assisting young people and their families in this way. The self-image. Having diabetes and injecting and having bruising and changes isn't a great look for people, and there's all sorts of other aspects around it to when somebody is growing up and going through all of the changes of adolescence and all of the thoughts and ideas that are going on, adding in something that might change their body image will be an important factor. Personality, we're all different. Everybody's got a different personality, and some people will do things in a different way, and we just have to understand the young person and the family and take that into account. Family and parent factors, clearly we heard the importance of the support that a family is able to provide to all the young people going through. And everything that we're talking about, we need to have both addressing for the young person and addressing for the family, and we're running this journey from being completely dependent to completely independent, and we allow that process to happen, but it's a very challenging process to go through, and we need to work very closely with family around all of this. And then finally, and I'll come back to this, motivation. It's all around, most of what we do as health professionals in any chronic condition is around motivating people. It's relatively easy to come up with a management plan to say, I think you need to have 4 injections a day, or I think you need a pump, or I think you need 2 injections, whatever. It's much more difficult to assist that young person and that family to actually undertake what the agreed management plan is, and that is mostly around the motivation. So in diabetes, some examples of what we're doing, and this is just to give you an idea of the complexity of what we actually are asking of people all the time. And if you split it out into different parts, there's insulin administration. How many injections? Or where do we give it? Do we rotate? Do we make the line changes often enough? Do we do it every 2 or 3 days, or is it lagging behind? What type of insulin is being used? When is the insulin being given? Is it being given before the meal, after the meal, at the right time? Are there some injections being missed? With the boluses of insulin through an insulin pump, are we calculating the amount? Are we doing the carb counting correctly? Are we putting it in before or after the meal? Is the bolus actually being given? So I talk about, with the insulin injections, a 10-cent rule. And I ask people to picture that they've done an injection. They've got a tiny little pinprick where the injection's been done. Picture that, you put a 10-cent coin over the top of your injection and you sticky tape it on. And you don't go anywhere through that whole 10-cent coin, because you can't inject through a 10-cent coin, and you don't go back there for at least 2 weeks. So here's some examples of, you saw some pictures of Lisa's kids. So here is my daughter. My son refused, even when I offered him as a 13-year-old that I'd give him all of the $2 worth of 10-cent coins at the end. I just don't understand why $2 wasn't inspiring to him. So my daughter, who's 11, I said, do you want to come and have a picture here? And I'll let you have the $2 at the end. Oh, yes, please, Dad. So this is my daughter's arm and my daughter's belly and my leg, just to show you this idea of how big an area you actually need to rotate. And we even use teddy bears to educate people. But here is an example. If you don't rotate your insulin, and this young person many years ago allowed me to take the photo, and I've told him that over the years I'll be using it to educate, and there is no way you can tell who that is clearly, but this young person was absolutely, religiously doing one aspect of their management. I was very confident that this young person is giving their insulin, okay? I'm convinced. But unfortunately, another aspect of the management, rotating away from the lumpy area and moving it around and following that 10-cent rule, I'm very convinced is not being able to be well managed. So that's where some aspects are working well and others aren't. And we've got to understand why it is that somebody might use these areas. And there are reasons. If you have lipohypertrophy, which is the term for fatty tissue swelling if you repeatedly give it, and this is a very, very significant example, most people just have subtle swellings, then the reason behind this is that it doesn't hurt as much. That's why somebody might choose to do it often. So they are doing one part, but they're not managing to do everything that we're discussing. So other aspects of management that may be challenged. Blood glucose levels. How often are you entering into a book or in some way recording them and thinking about them? Are you downloading the blood glucose levels, or are you using them to give extra insulin? Are you interpreting them and looking at the patterns? And that's one of the great challenges we're going to face in the near future with the new continuous glucose monitor rollout, that people will be using it and having lots and lots and lots of data, but will they be then stopping and reflecting on that data? Will they just be reacting, or will they be using it to change their management? And so if you can predict a blood glucose level, then you might be able to prevent. We've heard that you can't always, but if there is any chance of making a difference, it's trying to understand in this situation typically what will happen when I do my sport, or when it's a weekend, or whatever it happens to be. So we need to actively, regularly review the blood glucose patterns, and if you can identify it, we may be able to solve it. So that the painful part of diabetes can be the injection, the physically painful part. The physically painful part may be doing the finger prick, but the mentally painful part can be getting around to actually stopping and looking and reviewing your levels on a regular basis. That is one of the challenges that we face. And then looking at the other aspects of the diabetes management, including dietary modification, activity, clinic attendance, investigations, etc. People may struggle with each of these different areas. And as an example, here is a publication from many years ago looking at the outcome of diabetes based on how many boluses of insulin somebody gives in their pump and how much they're using it. And generally, the more boluses that are given, the better the HbA1c. But here is a person who is doing 1 or 2 boluses a day, but has an HbA1c very close to the target range. And here's a person who is doing 10, 15 blood glucose levels a day, but having a much higher blood glucose average. So as a group, we can say, this is what you need to do. But as an individual, it can be much more challenging. That's where we need to understand the individual part. And here's a person with a lot of blood glucose, so a lot of insulin bolusing. Based on this column down here, there's a lot of use of the insulin pump, but this is a record of the blood glucose levels. And you saw Lisa's picture before of all the blood glucose levels. What can you see on this? Nothing, because the person is pushing the button to give all the insulin, but is not putting any blood glucose levels in. And it's important that the adherence fluctuates. So here is a day where on this little rectangle there is a record of all of the blood glucose levels, all of the insulin boluses, all of the carbohydrate entries, and I can tell you that's completely blank. Yet in the same fortnight, on the same person, here is a day where there have been 4 boluses, 4 finger pricks, lots of carbohydrate entries. So it's not consistent over time. So how do we actually make a difference? What we want to do is understand why somebody is struggling with some aspect, decide and interpret if it's actually happening. We want to identify and acknowledge that there is a challenge, and if there's a reason behind it, we need to understand. And the person who is not doing a finger prick at school because they are being bullied, we can offer them all sorts of inducements, but until we fix the bullying, we may not get anywhere. If, however, they're not doing it because they genuinely forget, putting an alarm into their phone or into their pump or into their meter or something may truly make a difference. But we can have as many alarms as we like. If the person really doesn't want to do it, they're not going to necessarily do it. So very important to distinguish, is it forgetful? If they're scared of going low, they may not want to give their insulin and therefore, or give as much insulin. So we've got to understand and to address that and identify and treat any underlying mental health. And we have to have a really good working relationship with the individual and the family. We have to be, as I said right at the start, honest and non-judgmental, okay? Everybody is in a different situation to everybody else, and all we can do is be assisting as much as we can. Having educational interventions, using telemedicine, mobile phones, reminders, all sorts of things can be useful. Having strategies, if somebody continually has to wait for many hours in a clinic to be seen, that will put them off wanting to come along. And we need to respect everybody's time, and we need to do the best we can to get the best structural outcome if possible. Sometimes there will be behavioural strategies, as I said, such as visual reminders or alarms. We need to assist people in problem-solving skills and thinking through in advance of a situation. So if somebody is struggling at a certain time, then we might be able to say to them, okay, you can think about, if you're in this situation again, how will you actually act and what will you do? And peer and family support are very important. There can be specific mental health programs or psychosocial programs where motivational enhancement therapy, resilience training. Some of these can be targeted to young people, and there are a lot of examples of this in the medical literature. Now, just finally, the last minute or two, I just want to explain, I think about any behaviour, whether it's doing more finger prick tests, whether it's reducing food intake to assist in weight management for a different condition, whether it's taking more Ventolin puffers, whatever it is, it's the environment, the knowledge and the motivation. So, do you know what to do? Do you have the setup in your environment to be able to do it? And then are you actually interested and motivated to do it? And knowing which one of those or multitudes of those is where the issue is, assists us in understanding. So I do something as a bit of a muck around with the kids. I'm always mucking around with them, where I'll say to them every now and then, one of the kids, and say, if you did more blood glucose tests, you're doing 1 blood glucose test a day. If you came in a month's time and you were doing 3 blood glucose tests a day, would you do that if I gave you $1 million in a month? And most of the time they say, oh yeah, that'd be great, $1 million. Okay, fantastic. I've had a couple of kids say, no, not interested. What about 2 million? Nope, 5 million. I just hate diabetes, I don't want to do it. That gives quite a lot of insight. I'm not suggesting for a moment that we offer all of the kids lots of money in order to do their blood tests. But the point of the exercise is to say, it's not that they're physically not able to do it. It's that they know what to do, they've got the tester there, they just aren't motivated to do it. We need to understand what could be the motivating factor for them. So in my wallet, I carry around my $1 million. And it's say 1 million Zimbabwe dollars, and you can get your own for $2 on eBay. And I did meet a family the other day who were from Zimbabwe, so I was very excited I could actually chat to them about the actual $1 million. Now, the last 30 seconds, I just want to say, the mental health and the understanding why people do things is the key, but there's a whole lot of other strategies we can think about. Simplifying things, using a delivery aid such as a cassette box, working on the motivation, as I said, short-term, not long-term goals, educating and making sure that they are making their decisions on the basis of knowledge around what they need to do, and then giving the young person the self-control and the independence, being prepared to compromise. And sometimes there'll be further levels that we need to go to. Having a contract, sometimes some people report being helpful, peer support groups, psychological involvement. Okay, thank you very much.